Welcome.
Okay.
Honorable dignitaries, scholars, delegates, respected teachers, and all my dear students, a very good morning to one and all. It gives me an immense pleasure to extend you a very warm welcome on behalf of Department of Shalya Tantra, Loknete Rajarambapu Patil Ayurvedic Medical College, Hospital, PG Institute and Research Center, Islampur, who has arranged the national webinar on clinical aspects of anorectal diseases. Now I, Dr. Snehali Katkar, a lecturer in Shalya Tantra Department, Loknete Rajarambapu Patil Ayurvedic Medical College, Hospital, PG Institute and Research Center, Islampur, request Dr. Amit Shedge, HOD Shalya Tantra, to give a preface of today's webinar.
Thank you, madam. A very good morning, one and all. Myself, Dr. Amit Shedge, giving preface of today's webinar. So today, our department, Shalya Tantra department of our institute, Loknete Rajarambapu Patil Ayurvedic Medical College, Hospital, PG Institute and Research Center, Islampur, has arranged a national webinar on clinical aspects of anorectal disease. It gives me an immense pleasure to welcome today's webinar speaker, Dr. Lakshmikant sir, Professor and PhD guide of Department of Shalya Tantra, Sri BMK Ayurved Mahavidyalaya, Shahapur, Belgavi. And second speaker of our today's webinar, Dr. Shekhar Patil sir, Assistant Professor, Department of Shalya Tantra, Vasantada Patil, Ayurvedic Medical College, Sangli. I also welcome our institute's respected Dean sir, Dr. Virendra Minkre sir, our PG Director, Dr. Pramod Kanap sir, PhD Director, Dr. Ajit Patil sir, and Office Superintendent, Sandeep Yadav sir. I also welcome all the respected faculties of our institute, as well as from other institutes who have participated in this webinar. I heartily welcome all the PG students and UG students who have participated in this webinar through the online media. This webinar is arranged to give detailed information .
नेट हमारा गया
Ma'am, there is a technical glitch. You can introduce our first guest.
Okay, sir. Thank you, sir. Now let's head on towards the first session of today's webinar on clinical aspect of anorectal diseases. The first session will be conducted by Dr. Lakshmikant sir. Now, I would like to invite Dr. Shamal Shirare, Assistant Professor, Department of Shalya Tantra, L.R.P. Ayurvedic Medical College, Islampur, to introduce today's distinguished speaker of our webinar. Towards you, Dr. Shamal.
Unmute, ma'am. Unmute yourself.
Good morning, everyone. I, Dr. Shamal Shirare, welcomes our today's speaker, Dr. Lakshmikant, Professor Shalya Tantra from Sri BMK Ayurveda Mahavidyalaya, Shahapur, Belgavi, Karnataka. He completed BMS from Rajiv Gandhi University, Health Sciences, Bangalore in 2001, MS from similar university in 2007, and PhD from Jamnagar in 2012. he teaching experience is 16 years for each UG, PG, and PhD as a PhD guide. He completed 3 PG guideship, ongoing for 5 PG students and 2 PhD students. He having Best Surgical Consultant Award in 2021. He is ex-BOS member in KL University, ex-HOD of Research Methodology and Medical Statistics, reviewer of International Journal JISM, article published 11, national and international also, research project 2, and CME attended 6. Paper presented 7, webinar presentations 8, and guest lecture 2. He was a chairperson for 8 international and national seminars, workshop 15, and seminars and conferences 15. He had radio talk for once. Now I request to start their valuable sessions, webinar sessions.
Thank you. Very good morning. Am I audible?
Yes, sir.
Thank you, sir. So now I am going to share my screen. Sir, is it visible?
Yes, sir.
So very good morning once again. I am really thankful to Dean of the esteemed college, Dr. Virendra Menkere sir, who is my senior most in my PG studies, who is the godfather for me in this field. So myself, Dr. Lakshmikant, I am proud to say that I am working in an institution which has India's first institution with NAC and NABH accreditation in highest sector. And the topic given me is clinical aspect of rectum carcinoma. So as we know, there are no specific etiology for carcinoma of rectum because n number of causes are there, and which cause results into which type of carcinoma or which area of carcinoma, it is exactly not known. So it is clinical aspect. So directly coming to clinical examinations, first I want to highlight like pathology of or pathogenesis of carcinoma of rectum, where some precancerous conditions are there. If it is not treated, these causes the carcinoma of rectum. Other causes are there, dietary causes are there, some chemicals are there, but some precancerous conditions which I want to highlight is villus papilloma. So papilloma is a benign condition. If it is not excised in time, it may result into carcinoma. One. Second is adenomas are there. Adenoma is a benign tumor, whereas adenocarcinoma is a malignant tumor. The rectum, it is lined by columnar cell epithelium. When in columnar cell adenoma occurs, so it has to be removed or that is managed. Otherwise, in time, it becomes a carcinomatous lesion, so termed as adenocarcinoma, which is most common condition of carcinoma of rectum, that is adenocarcinoma, which is termed as a columnar cell adenocarcinoma. And some familial polyposis conditions are there. These are polyps like structures. So in the rectum, this has to be excised if diagnosed early. Otherwise, this results into carcinoma. When we come to carcinoma, any type of carcinoma, we must explain what are the appearances, macroscopic and microscopic appearances. What does it mean? Like on naked eye, how the lesion appears. And in microscope, what is the appearance of those cells, malignant cells. So it differs actually. Like on naked eye, it is termed as macroscopic appearance. Mainly, it is of three varieties. Like when the lesion, it looks like a cauliflower-like growth. So we know that cauliflower. So it looks like that flower, that shape. So usually it is proliferative variety. And interesting thing is, this growth, it is generally, most commonly it is occurred at rectum ampulla. Now, when anything comes to ampulla of rectum, when ampulla of rectum is loaded or full or something there in the ampulla, so person or patient urge for defecation. Here what happens, when growth is present in the ampulla of rectum, patient feels always like something is present in the rectum. He always feel to urge for defecation. So repeatedly he like goes for defecation or do the act, but he never gets satisfied by this act because the lesion is situated in the ampulla only. He never gets satisfied. So this is first variety, that is termed as a proliferative variety. Second variety, that is ulcerative variety. So here the lesion is, there is no growth, but ulceration occurs. As we know, on that is a colonoscopy or sigmoidoscopy, we can differentiate depending on the edge of ulcer or margin of ulcer. As we know, it is, if it is undermined, it is a tubercle. But in case of carcinoma, it is everted or raised edges actually. So ulcerative variety and proliferative variety, especially in case of proliferative, bleeding takes place. See, the whole night bleeding takes place. Ampulla of rectum is full of blood, or that is that content, some stool, maybe some mucus, right? When patient rises from bed, because full of rectum, that ampulla of rectum, patient feels like urgency of this defecation. He rushes to toilet. Okay. And when he starts like defecating, he passes lots of blood. Means some amount of stool also, some mucus also. But he never gets satisfied with this act. Because if a proliferative variety is there, as I told, so patient never gets satisfied with the act. So
sorry to, hello.
Hello.
Sorry to disturb you, sir. Lakshman sir. Slide is not seen on the screen. Slides, only one slide has been seen. Slides are not seen.
No, sir. I am not changing. I am just explaining now.
Okay.
Later on, I will do. Yes, sir. Yes, sir.
So, okay.
Is it okay? Is it okay, no, sir?
Okay, sir.
Yes, sir.
You can continue. Okay, thank you.
Yes, sir. So, when patient like rushes to toilet, passes lots of blood, so medically it is termed as early morning diarrhea. So, these are the features found in rectal carcinoma. These are the clinical features. Why I am highlighting these points is, so if patient comes with early morning diarrhea or spurious diarrhea, means the lesion may be either proliferative or that is ulcerative. When patient complains of never get satisfied with the act, it is proliferative. And when patients like, especially in this case, the bleeding is painless bleeding. Here we have to differentiate. This painless bleeding, it is because of internal hemorrhoid or it is because of carcinoma of rectum. In case of internal hemorrhoid, first and second degree hemorrhoid bleeding will be there. But the bleeding, it is explained like it is splashes in the pan. This differentiates the early morning diarrhea in case of carcinoma of rectum. Why early morning diarrhea occurs in carcinoma of rectum? It is because of this proliferative variety of ulcerative variety, where blood is get collected, that is in whole night. In early morning, patient rushes to toilet, passes lots of blood. Bleeding is painless. Third variety, that is annular variety, or it is also termed as a tubular variety. And this annular variety usually occurs in upper part of rectum, that is pelvirectal junction or rectosigmoid junction. Now see, when a lesion is present in the rectosigmoid junction, this annular variety, the lesion is, it get fibrosed or the lumen get narrowed. When lumen get narrowed, the area is at rectosigmoid junction. So the content of the bowel, it will not descend into the rectum. It is present in the sigmoid colon only. Until and unless when the content reaches the ampulla or full the rectum, patient never had urge for defecation, because content is getting collecting on over the in the sigmoid colon only, over the rectum, not descending into the rectum. So patient himself, he feels like patient is having constipation. Then he starts consuming some laxatives. So as he starts consuming laxatives, small amount of pus is stool is get passed. He increases the dose of that laxative. One fine day, he starts diarrhea, loose motions. Then he stops himself the intake of those laxatives. Once he stops the intake of laxatives, again constipation starts. This nature of bowel habit is termed as alteration in bowel habit, that is altered bowel habit. Why I explain this here is, if patient comes with a complaint of this altered bowel habit, means sometimes patient is having constipation, sometimes patient is having loose motion, means we should keep it in mind, it may be annular variety of carcinoma of rectum, that is macroscopic type. Got it? See, this is the diagram of proliferative variety, that cauliflower growth. See, this is benign lesion. If it is not treated, it is becomes pre-malignant condition and becomes malignant. So this is adenocarcinoma variety. So later on, that is, it is a spread actually. You concentrate here. First variety, that is proliferative variety. Second variety, you see here the ulcers. You just check margin and edges of this ulcer. So, and this necrosed some areas of this ulcer, it indicates carcinoma. Maybe in rectum, maybe in colon, but the edges are averted. That is ulcerative variety, second variety. Annular variety, we can diagnose on the basis of barium enema. When we give the enema, or that is meal, see, the descending colon, it is clearly seen. Sigmoid colon, it is clearly seen. When it reaches rectum, this becomes narrow because this is rectosigmoid junction, where circumferential spread of that annular variety, it causes fibrosis or narrowing of lumen of rectum. As I told like earlier, like the content is collecting in this area only, that is sigmoid colon only. It is not reaching to this rectum. Patient had constipation. Because of constipation, patient starts consuming laxatives. Lastly, he starts diarrhea. Again, he stops consuming medicines. Again, he complains of constipation. This alteration in bowel habit, it is mainly due to this annular variety. Next comes to microscopic variety. Earlier it is macroscopic, proliferative, ulcerative and annular. In microscopic, when we take the cell, sent for the histopathological report studies, we will get three varieties. Main variety of carcinoma of rectum, it is adenocarcinoma. Rectum, it is lined by columnar cell. Anus, last part, it is lined by squamous cells. In case of rectum, that is columnar cell, when these are enlarged or that is growth takes place, adenoma occurs, benign condition. When it is not treated, it may get converted into malignancy termed as adenocarcinoma, which is termed as columnar cell adenocarcinoma, which is again subdivided into, like in microscope, if we say, if we can differentiate the malignant cell with the normal cell, that is termed as well differentiated adenocarcinoma. If it is doubtful, means the growth is malignant or not, may be malignant. If it is, there is a doubt, it is averagely or moderately differentiated. But last variety, though it is a malignant cell, we cannot differentiate this malignant cell with the normal cell, which is termed as undifferentiated. It is dangerous. It is termed as anaplastic variety. This is about columnar cell adenocarcinomas. Next is colloid carcinoma. When adenocarcinoma is untreated, in the colloid carcinoma, in the adenocarcinomas, the mucoid degeneration takes place. Abundant mucus is get collected within the carcinoma cells. This causes pushing of nucleus towards the periphery, which looks like a signet if a signet ring appearance. So such type of colloid carcinoma is termed as a secondary colloid carcinoma, because this occurs after the manifestation of adenocarcinomas. Some other conditions are there, which is termed as a primary colloid carcinoma, which does not follow the adenocarcinomas. Means earlier there is no adenocarcinoma, but directly the cell get filled, that is mucoid degeneration takes place, that is nucleus is pushed towards the periphery, same signet ring appearance is there. Without occurrence of adenocarcinoma, if it occurs, it is termed as a primary colloid carcinoma. Actually, this is rare if it occurs. This primary colloid carcinoma, it causes some complications like fistula in ano. That is why in aged person, patient presents with fistula, first we have to rule out this colloid carcinoma. Otherwise, if we put Kshara Sutra, that is do some interventions, if it is diagnosed later, it is diagnosed like it is a colloid carcinoma, it comes to our neck only. We have to rule out this colloid carcinoma, because primary colloid carcinoma complicates like a fistula in ano, and it is poor in prognosis also. Because of that reason, and early metastasis occurs and it grows rapidly. So we have to be aware of this primary colloid carcinoma. Next is rarest variety. It is squamous cell carcinoma. This squamous cell carcinoma, it is extension of carcinoma from anus to rectum, because rectum is lined by columnar cell, anal canal is lined by squamous cell. If a carcinoma occurs in squamous cell, that is in the anus, and it spreads in a retrograde fashion towards the rectum, when the rectum is involved, that is termed as a squamous cell carcinoma of rectum. So invasion of, that is anal carcinoma. These are the microscopic varieties, that is columnar cell adenocarcinoma, which is the most commonest variety, colloid carcinoma, rare variety. Next is squamous cell carcinoma, extremely rare variety. So these two are important, that is macroscopic and microscopic variety. See, these are columnar cell carcinomas. See, these are signet ring appearance. This is nucleus. Here you can see this is colloid carcinoma. Here it is clear. See, this is the signet ring cell, where nucleus is pushed towards the periphery. The cell that is vacuole, it is full of mucus. So this is a colloid carcinoma variety. Next, coming to spread. So after that is diagnosing on the basis of clinical features, we should know about the spread of carcinoma. Like every carcinoma has a local spread, venous spread, lymphatic spread, sometimes a transperitoneal spread also. Here, in case of carcinoma of rectum, the local spread will be very that is interesting is a thick fascia is there which protects the malignant cells spread from rectum to outside the rectum. That is termed as fascia propria or perirectal fascia it is. When local spread takes place, the fashion of local spread is circumferential rather than that is a longitudinal. It not that is a longitudinal spread means upper and lower. It is a tubular structure rectum. So upper side that is towards sigmoid colon, lower side towards anal canal. This this vertical spread it is restricted in case of carcinoma of rectum. But circumferential spread, that is the whole circumference of rectum is involved, and 1/4 of circumference of rectum spread is time taken for this 1/4 of circumference taken is near about 6 months. First the mucus is involved, later on submucous of the rectum is involved, then muscle coat is involved, and it reaches serous coat. So this sequence, like this spread up to 1/4 of circumference of rectum, it takes near about 6 months, and the whole circumference of rectum it takes about 2 years. 18 months, that is 2 years. Here, when malignant cells spreads to, so that is from mucus to muscle coat, means first mucus coat is involved, next submucous coat is involved. When it reaches muscle coat, lymphatic spread takes place. As soon as the malignant cells reaches or infiltrates muscle coat, lymphatic spread starts. Means in carcinoma of rectum, lymphatic spread is early compared to venous spread. Distant metastasis is late compared to lymphatic spread. Means lymphatic spread is early because when muscle coat is infiltrated or involved, lymphatic spread starts immediately. Next spread, see this is like 1/4 of that is the area it takes 6 months, and the whole circumference it takes 2 years. When local spread takes place, like after 18 months or 2 years, when fascia propria is penetrated, the malignant cells spreads outside the rectum. It involves the surrounding structures of the rectum. In males and females, the structures differs, especially anteriorly. Anteriorly in males, immediate anterior to rectum, bladder is there, and prostate is there, seminal vesicles are there. Whereas in case of females, uterus and vagina is there. That means in case of males, when this anterior spreads takes place, so in males, bladder, prostate and seminal vesicles are involved. Whereas in case of females, uterus and vagina is involved. Whereas when this growth spreads laterally outside the rectum, in both the that is gender, ureters are involved. Means here again one more thing clinically, like when patient comes to you, like pain in bilateral that is flanks, if we take an scanning that is USG, where bilateral hydronephrosis is there with bilateral hydroureter, aged patient is there, then we should think of any growth present in the rectum, because in case of carcinoma of rectum, if lateral spread takes place, it involves both the ureters, where obstruction of both the ureter takes place causes bilateral hydroureter and hydronephrosis. Secondary hydronephrosis is there, that in that condition you have to rule out carcinoma of rectum. Clear? Next, posteriorly. So posterior to rectum, that is sacrum is there, or presacral fascia or sacral plexus is there, where when spread takes place posteriorly, sacral plexus involved. What is the clinical feature here? Bilateral sciatica, because involvement of both the sciatic nerve takes place. Patient is having bilateral sciatic pain. Again, when patient comes to your OPD with bilateral sciatic pain, not only X-ray, better take on UHG report or colonoscopy report so that to rule out this carcinoma of rectum. This is clinical, it is very important. Next comes to lymphatic spread. As I told, it is quite early in case of carcinoma of rectum compared to venous spread because immediately after involvement of muscle coat, lymphatic spread takes place. So, lymphatic spread, that is, the involved lymph nodes are first epicolic nodes, later on pararectal nodes. These are nodes termed as pararectal nodes of Garota. Then intermediate nodes, later on that is inferior mesenteric nodes. Why it is important? Because during surgery, what are the nodes? Which are the nodes are involved? Those nodes are excised, including the lesion that is termed as radical excision. Right? So, inflammation of nodes or palpable lymph nodes not only due to carcinoma, it may be due to inflammatory condition also. Here again, clinically we have to differentiate. It is inflammation of nodes. It is due to any palpable nodes. It is due to any inflammation, or it is due to malignant conditions. That is also important. See, these are the nodes. See this. When rectum, it is divided into like inferior, middle, and superior parts. Upper third, middle third, and lower third. So these are the involved lymph nodes. Then coming to venous spread, that is blood spread. Compared to lymphatic spread, blood spread is late, but when blood spread takes place, when it starts, first involving organ or structure in the body is liver. So I should not use such words like पूरे दुनिया में या फिर पूरे ग्लोब में भारत एक ऐसा देश है, हर कोई अटैक करके गया है. स्पेन आए, डच आए, मुगल्स आए, ब्रिटिश आए, हर लोग आए, हर लोग आके यहाँ पे कन्वर्शन किए, चेंज किए. जैसे ग्लोब में इंडिया है ना, वैसे हमारे बॉडी में लिवर है. इट गिव्स स्पेस, इट अलाउस टू ग्रो to itself, like it audible nahi sir, it is audible. Hello.
You are audible, sir.
Audible. I got the message. That's why I got the message. That's it. Okay. So liver is such an organ in our body, like, and it gives a space, like, in case of carcinoma of rectum, what happens? Through inferior mesenteric vein, via portal vein, it reaches. When these malignant cells reaches liver gives space to settle in the liver. These lesions grows, these damages liver. Later on, these detached from the liver. Some cells are detached from the liver also. From liver, through inferior vena cava, right part of the heart, that is right atrium and right ventricle. From right ventricle, these like flows into or reach to lungs. Second commonest organ is lung. My intention is to, in case of carcinoma of rectum, if distant metastasis occurs, means blood spread occurs, liver is the first organ to involve, lungs are second organ to involve. When malignant cells are get detached from the lungs, it reaches left part of the heart through left ventricle. From aorta, it may reach anywhere in the body, like brain, bones, adrenals, spines. So, what is the clinical importance here? Means when patient comes to clinic, like complaints of like early morning diarrhea, like other things, I will explain later those clinical features. And on palpation, if liver is palpable, if it is irregular, hard, means you have to think history is important. Since how many years he is suffering from those complaints, on palpation, that is, we are getting this hepatomegaly, ascites may be there, right? And if patient complains of like any respiratory symptoms, epistaxis, or else that is on auscultation or on chest X-ray, if we can able to see the lesions, metastatic lesions. So you have to do PET scanning, you have to, that is search for the primary lesion. Then last year, in case of carcinoma of rectum, that is fourth variety of spread, it is a transperitoneal spread, means. See, as we all know, the rectum, when it is divided into three, upper third, middle third, and lower third, only some part of rectum is lined by peritoneum, not the whole rectum is lined by peritoneum. The upper part of rectum, it is lined by peritoneum. When peritoneum, that is, comes, upper part of rectum, it reflects over the bladder. There it leaves a pouch. It is termed as a pouch of Douglas. Some part of middle and lower part of rectum is a divide of peritoneum. When this transperitoneal spread takes place, means if the lesion is present in the upper part of rectum, it may spread into peritoneal cavity, which is termed as transperitoneal spread. If the lesion is present in the lower third of rectum, this transperitoneal spread usually never occurs. Got it? Huh? Then, see, this is the venous spread, as I explained, like from rectum, it reaches inferior mesenteric vein. Through that, that is through via this portal vein, it reaches liver, and it may settle anywhere in the liver where it grows, which is termed as a distant metastasis or metastatic growth. From liver, some cells detached through inferior vena cava, it reaches the heart and it involves the lungs. So liver is the first organ, means if hepatomegaly is seen, if it is irregular, hard, means anywhere lesion may be present anywhere in the, that is lower part of the body, you have to rule out by doing PET scan, by doing suspected, depending on the signs and symptoms. Coming to stages of carcinoma of rectum. Text, it is divided into, that is, it is given as the Duke's classification and TNM classification. TNM is most followed, that is a classification where you can see that is in the DAS. So T stands for tumor, that is a size of tumor. N stands for involvement of lymph nodes. M stands for, that is a metastasis. If you take a T, that is a carcinoma when it is present in the mucous coat, that is origin or it is started, it is not diagnosed also. It is difficult to diagnose. It is termed as a T1S, carcinoma in situ. Then T1 is there, involvement of mucous submucous coats. T2 is there, involvement of along with the mucous submucous muscular coat is involved. Why this staging is important? When it is written like T2, N1, M0, that indicates, because earlier I told, when muscle coat is involved, lymphatic spread starts. In T2, along with the mucosa and submucosa, muscle coat is involved. If T2 is there, if muscle coat is involved, if nodes are palpable, they will write like N1, means nodes are enlarged. So T2, N1, if they are giving like M0, means metastasis is not there, means lymphatic spread is there, but blood spread is not there. Liver is not involved. If they are giving like a T4, N1 or N2, M1, means along with all parts of rectum, surrounding structures are also involved, with distant nodes are also involved, and liver is also involved. That is, distant metastasis is also there. So this is clinically this important. TNM classification. Other classifications are also there, but TNM is most reliable. See, this is a local spread, as I am telling. Like you can see here, first is a T1, and then that is a T2, then T3, T4, like spreading into surrounding structures. Coming to clinical features. So macroscopic and clinical features are having a good connections. Like usually carcinoma, it occurs in the old age, above 45 years. So this also disease of old age. If it occurs in younger, means it is dangerous, where prognosis is poor. Usually it is a disease of old age, but carcinoma of rectum occurs in the younger age, prognosis is poor. And patient usually that is comes after 6 months or after 1 year of commencement of the disease, because so he himself don't know about this features. Like he himself, like if patient has bleeding for rectum, piles, he himself that is diagnosed like he is suffering from piles. He will search YouTube, he will search Google, he will take some medicines. Later on, he will consult some local physicians or surgeons. Like so commencement of the disease, that is after 6 months when features are noticed. So main complaint of this disease is bleeding per rectum, that is painless bleeding. That is why I told, like you have to differentiate between internal hemorrhoid, that to first and second degree hemorrhoid with the carcinoma of rectum. In case of first and second degree hemorrhoid, the nature of bleeding is splashes in the pan, whereas in case of carcinoma of rectum, nature of bleeding is lots of blood, that is early morning diarrhea or spurious diarrhea. So bleeding per rectum is most constant and earliest symptom of the disease. Along with the blood, patient may possess a mucus. Like I told, like proliferative variety and ulcerative variety, especially in case of ulcerative variety, and mucus discharge is there. If it is get infected, pus may be there, cells may be seen in stool examination. So bleeding per rectum, that is along with the blood, mucus, and some small amount of stool is passed actually. So the bleeding is painless. Especially it is at the end of defecation. So theoretically it is said end of defecation, bleeding is more, it is said to be. Next complaint is alteration in bowel habit. Means every patient don't have bleeding per rectum and alteration bowel habit, because it depends on macroscopic variety. If patient is suffering from proliferative and ulcerative variety, patient complains of early morning diarrhea, bleeding per rectum. If patient is suffering from annular variety, where rectum is empty, bowel is above the contents are, that is above the rectum, that is in the sigmoid colon only, where patient is having constipation, he himself starts taking some laxatives, Camchur, Isabgol, anything what he will get in the medical shops. And when he increases the dose, because of he feels like this drug is acting on constipation. If he increases the dose, he starts diarrhea. He feels like, I am suffering from diarrhea. He stops that medicine. Once he stops the medicine, again he suffers from constipation. This is termed as alteration to bowel habit. If this such feature is there, if patient comes with such feature, so it is due to annular variety of carcinoma of rectum. Next complaint is, as I told, early morning diarrhea. Usually it is seen in cauliflower-like growth, that is proliferative variety. It is already explained. Sense of incomplete defecation is there. This sense of incomplete defecation, it is never seen in ulcerative variety. It is never seen in annular variety. It is seen in proliferative variety. Got it, na? So later on, sometimes, that is like in case of annular variety, patient may have features of intestinal obstructions. Annular variety. Right? Pain, it is said to be late symptom, because every carcinoma, it is having silent features without pain. Usually I used to tell, like in classes, in classroom, who is very silent is very dangerous. So like that, in carcinoma also, usually it is a painless bleeding. Pain, if it is there, it may be due to that is like stenosing growth at that rectosigmoid junction, where colic abdominal pain. Otherwise, when it spreads surrounding structures, like posteriorly when it spreads, when sciatic nerve is involved, sciatic pain will be there. Then loss of weight, which is the most constant feature of any carcinoma. Patient gradually losing his weight. Okay, now this is very important. Then symptoms are associated with venous spread or blood spread, or it is termed as distant metastasis, which means when growth is limited to perirectal fascia propria, that is perirectal fascia, there is no distant metastatic features are there. After 18 months or 2 years, when it spreads outside, means when it spreads through vein, it reaches the liver. Unpalpable, liver is palpable, liver is hard and irregular, means this is termed as distant metastatic features, means hepatomegaly. Along with this, patient may suffer from mild jaundice, ascites, so distension of abdomen. These are symptoms which are associated with the distant metastasis. Then on palpation, we can palpate that large bowel which is filled with the stools, where that is we can palpate the liver also. Here important is rectal examination is very important in every case of anorectal complaint. When patient comes to you with anorectal complaint, without doing a digital examination or rectal examination, if we prescribe medicine or decide some interventions, so it is considered as a crime. So every patient, when comes to OPD with anorectal conditions, we should inspect, we should do digital examination. Possibly we can do proctoscopy examination to diagnose the disease, to rule out the conditions. So 90% of that is CR, carcinoma of rectum or lesions. Because present in the lower third of rectum, we can palpate. And if it is ulcerative variety, these bleeds on touch. Touch on bleed is a feature of a carcinoma. If proliferative growth is there, cauliflower-like growth is there, if it is in the lower third of rectum, we can palpate. If it is in the middle third, upper third, it is in case of upper third, it is very difficult to palpate. It is not at all palpable. But 90% of growth, if present, that is in the lower third of rectum, you can palpate. Especially that is a bimanual examination is done in case of middle third growths. So after diagnosing, to confirm, we can do the special investigations for carcinoma of rectum are, we can first do proctoscopy examination. If we are able to see, we can see the lesions, okay, otherwise go for sigmoidoscopy, or else in sigmoidoscopy, if ulcer is there, we want to, that is diagnose, we can take biopsy and send for the HPR, where we can diagnose, that is if this is this lesion, this ulcer is due to Crohn's disease, ulcerative colitis, or that is a carcinoma of rectum. Then barium enema, especially this barium enema is to diagnose that annular variety of carcinoma of rectum. Then CT is there, MRI is there, endorectal ultrasonography is there, and sometimes colonoscopy is needed. So this is about clinical presentations. If time permits, sir, can I continue with the treatment or can I stop here? Shall I stop? Hello. 11:58. कितना time हुआ?
No,
Sir, it's 11:55.
Continue.
Sir, 5 minutes में complete करना treatment. ज़्यादा नहीं लूँगा.
Yes.
Okay.
Okay.
Coming to the, yes, sir. Thank you. Coming to the treatment aspect. So, excision of the lesion. Here we use the term radical excision. Means the lesion above and below 5 centimeter, the normal tissues are excised or normal tube is excised with involved lymph nodes. So this is termed as radical excision. And for a distal carcinoma, actually, two methods are there: abdominal perineal resection or perineal resection. Abdominal perineal resection, it is termed as Miles operation, and perineal abdominal, that is first perineum is opened and next abdomen is operated. That is it is explained by Gabriel. Usually abdominal perineal resection is done. So preoperative, it is like abdominal preoperative explain that. So in case of carcinoma of rectum, that is preoperative measures are: first the bowel is cleared, rectum, sigmoid colon, that is completely it is emptied. So maybe you can use like laxatives or that is purgatives, enemas, whatever is feasible you use. You clear the bowel first, and under cover of antibiotics, because infection should not like occur post-operatively. So keep it in mind that is both aerobic and anaerobic infection. So the antibiotics are selected and electrolyte imbalance is maintained. It is corrected. Then bladder is like catheterized. That Miles operation is followed like abdominal perineal resection. So Mile in 1930, he advocated like two surgeons are there, or that is in first, that is first surgeon. First he will operate on the that is abdominal part. Later on he come to perineal part. And this is modified in 1938 by Lloyd and Davis. Like two surgeons are there. One first operate on abdomen, second surgeon that is on the perineum simultaneously. Where structures removed are that anal canal, or that is in case of distal third, involved lesion with 5 centimeters means anal canal, upper part of upper 5 centimeters, that is healthy tissue from the lesion with epi and pararectal lymph nodes, and any other that is above lymph nodes are involved, those are also excised. This is the position actually. After excision, so carcinoma of rectum, that is especially adenocarcinomas, these are sensitive to radiation therapy. So radiation therapy is advised, where adenocarcinomas like preoperatively, especially that is in adenocarcinomas, preoperatively 2000 rads of radiations are given in 2 weeks. Later on, that is if lesion is within 8 centimeters of the anus, extra that is 500 rads are radiated through perineal route. Then regarding chemotherapy, so actually it is doubtful, but it works or not. Anyhow, 5-fluor uracil, it is implanted in case of carcinoma of rectum. Along with the 5-FU nowadays, that is combined therapy like leucovorin and levamisole is added. Some surgeons, that is oncosurgeons, prefer for immunotherapy also, that is interferon alpha 2A and some other that is there. Thank you. Sir, thank you.
Thank you, sir. Now moving on towards the next session of today's webinar. The second session will be conducted by Dr. Shekhar Patil, sir. Now I would like to invite Dr. Shamal Shirare, Assistant Professor, to introduce today's distinguished speaker of our webinar. Topic of his keynote address is Clinical Aspect of Bhagandar. Towards you, Dr. Shamal.
Thanks, Dr. Snehali. Now I will welcome our today's second speaker, Dr. Shekhar Patil, Assistant Professor Shalya Tantra, Vasantdada Patil Ayurvedic Medical College, Sangli. He completed his BMS from RGUHS, Bangalore in 2003, MS from SDM College, Hassan, Bangalore, 2008. 15 years teaching experience. He published 4 national and international articles, 3 papers presented, CME attended 1 seminar and conferences 10. Now I request to sir to start their sessions. Please, sir.
सर आवाज येत नाही.
येतोय का? हॅलो.
Yes, yes.
Yes. Can I share my PPT?
Yes, sir.
Just a minute. Screen. Whether my PPTs are visible? Amit sir?
Yes, sir. Yes, sir.
Yes. Yes. First of all, I am thankful to Dr. Virendra Medkari sir, the Dean, Islampur College, and also I am thankful to Dr. Amit Shedge, Professor and HOD of Islampur Ayurvedic College. And also I am thankful to all the faculties of Shalya Tantra Department, Ayurvedic College, Islampur. So today I am going to discuss regarding the clinical aspect of Bhagendara. Yes. So starting with the first slide. So just I want to highlight the contents of my topic so that all the visible students which are joined, they should know what exactly I am going to talk about. So first point I am going to discuss different disorders at anal region. Or other disorders which are related to anal callus, so that one can get idea regarding the other diseases also. Now I am going to discuss regarding the next. I am going to discuss regarding the introduction of Bhagendara. Next I am going to deal regarding Ayurvedic management of Bhagendara. Then I am going to discuss regarding Kshatrika treatment. Next I am going to discuss on Fistula, the allopathic counterpart of Bhagendara. Next I am going to discuss the management of Fistula. Saturn division treatment, which is also allopathic counterpart of Kshatrika. And next, comparison between the Kshatrika and Saturn division. And lastly, I'm going to conclude with some of my opinion. Yes. So once again, I'm asking, sir, whether the slides are visible, sir, madam. Hello. Hello.
Slides are visible, sir.
Okay, thank you. So this is the picture which is showing regarding different disorders which are going to take place in the rectum as well as the anal callus. Even though the heading is rectum, this picture is of both rectum as well as the anal callus. So these are the layers of the rectum: mucous layer, submucous layer, muscular layer, and serous layer. So this is a disorder called as ulcerative colitis, which is going to occur in the rectum as well as the lower part of the long intestine. Okay, so this is a diverticuli. So this is nothing but a circulation which is seen in the rectum. So diverticuli may be anywhere in the intestine. So this is a polyp. This is a supralevator abscess, which is the abscess which is above the levator muscle. So this is the picture of fistula. This is the internal hemorrhoids. This is the external hemorrhoids. This is also one of ichthyorectal abscess. This is a creptitis, that is infection of the creptal glands, anal glands. This is also one more picture of abscess. And this is a carcinoma, so which Lakshmikant sir has explained earlier topic. So these are the internal sphincters. So coming to the next slide. So this is a slide of external piles. So you can easily appreciate this piles is covered with the skin. So how we are going to differentiate from the internal piles, that the skin is covered with the pile is covered with the skin. So these are the primary sites, 3 o'clock, 7 o'clock, and 11 o'clock. And this is one secondary which is coming in between, secondary piles. So this is the internal pile. So you can easily appreciate the internal pile is covered with mucous membrane. So it is a pinkish color. So easily you can differentiate between the external piles as well as internal piles. So this is a prolapse piles. You can appreciate it. Next, prolapse thrombose piles. The piles which is prolapsed, it is strangulated in between the sphincters of the anal canal. There are two sphincters, internal sphincter and external sphincter at the anal canal. So this piles is going to strangulate in between. So you can make out that. Next, it is a fissure in ano. Fissure in ano is nothing but a longitudinal ulcer in the anal canal. Okay, the main symptom will be pain, severe pain after defecation. Then this is a sentinel pile, that is sentinel tag. So according to Ayurveda, we can call it as a bhaya arch, but according to modern, we are not going to consider it as a external pile. It is just only a sentinel pile or sentinel tag. Then, so this is a fistula in ano. So we can appreciate the two openings, external openings, perianal skin openings. Here is one, here is one. That is fistula in ano, which we are going to discuss elaborately in our next slides. So this is a case of rectal prolapse. So this is a complete rectal prolapse. There are two varieties of prolapse, that is partial prolapse and complete rectal prolapse. So in partial rectal prolapse, only the mucus and submucus is going to prolapse, and it is not going to extend more than 3.75 centimeter. And the complete prolapse, which is going to include all the layers of the rectum, mucus, submucus, muscular, and serous layer. Okay, and it may extend up to 10 centimeter, but it is more than 3.7 centimeter. So this is the picture of rectal prolapse. So this is a anal wart or condyloma accumulata. So what is this condyloma accumulata? It is a common sexual transmitted infection which is caused by stalk. So here it is a stalk. Is it clear? So it is a stalk. So we can differentiate this anal polyp from the internal piles. So internal piles are not having stalk, but this polyp is having stalk. Then this is a case of malignant melanoma. Malignant melanoma is a carcinoma of the anal canal. Then coming to our main topic regarding Bhagandhara. So what exactly the Bhagandhara word means? So there we can divide this word into two words, Bhaga and Dharan. What is Bhag? The structures around the Guda, including Yoni and Basti. So you can see in this picture different structures around the Guda. Okay, so this is the rectum, and these are structures around the Guda, including Yoni, Basti. Okay, and Dharana means tear of the surface associated with pain. So there will be tear of this surface of these associated structures, and there will be severe cold. So that is the word meaning of Bhagandhara. Then coming to the review of literature, actually this font is not supported by this PC. So even though we are going to review this literature, there is a sloka. Okay. So what it means, a lesion which, what exactly the Bhagandhara means? A lesion which causes discontinuity of the skin in the vaginal, rectal, perineal regions, and which is associated with tearing pain, severe pain. Okay, it is a result of bursting of Bhagandhara Pidika. It is a result of bursting of Bhagandhara Pidika. So you can appreciate here. So this is a Bhagandhara Pidika, and it is going to burst, and then it is going to lead to Bhagandhara. So Bhagandhara, there are two openings, as all of you are knowing. So this is a perianal skin opening. We can call it as an external opening. This is an internal opening, which is seen in the rectum. Come to next slide. So now we are going to discuss some of the Nidanas of Bhagandhara. So these Nidanas of Bhagandhara we can discuss in the three headings: Aharaja, Viharaja, Agantuge. So in Aharaja, extra consumption of Kashaya Rasa, Rukshiguna Yukta Padarthas, Vat Prokop Ahara, and such other Apatti Sevanas. Then came to Viharaj. In Viharaj Nidanas, we can say Ati Vyavaya, Pravahana, that is training at the time of purification, Utkasana, Utukatasana. So this is one of the asana which is told in yoga. Ashwapristagaman, that is riding of camel ride. Then Hasti Pristagaman, that is riding over the elephant. Then Kathinasan, so those the asanas which are Kathin, which is explained in our Ayurvedic literature. And Vasti Netra Sangas. So Vasti Netra Sangas, that is the Vasti Netra which we are using for giving the Gudha Basti, we are using this Vasti Netra. So that Vasti Netra may injure the anal mucosa, and that will lead to the formation of Bhagendra. Then to Agantuja Vihar, Agantuja Nidanas, so injection of foreign bodies, Astishalya, Trina, Krimi. So these are all the Nidanas of Bhagendra. Then coming to the Sampratya of Bhagendra, that is pathogenesis of Bhagendra. We are going to deal it under the three headings. Sanchaya. Sanchaya means stage of accumulation. So Mithya Ahar Vihar or trauma is going to lead to the accumulation of dosha at its normal site. Then next stage, it is going to be converted to prakop, that is, we can call it as a stage of provocation. So doshas are going to aggravate further, and here the active dosha will be Vat, and the passive doshas will be Pitta and Kapha. So then next there will be Vilena Rupi Vriddhi at the same place, and then Unmargamita. Unmargamita means the dosha is going to spread in opposite direction. Okay. The next stage will be Prasara, that is stage of propagation. So here vitiated doshas migrate from their own place, and they are going to circulate throughout the body. So in this stage, what is going to happen in stage of propagation? The doshas which till now are in the normal sites, they are going to spread or circulate throughout the body. The next stage is Stana Samsaya, that is stage of localization. So in stage of localization, what exactly is going to happen? There will be Mas Rakta Doshti. Doshas are going to lodge in the Gudda, and patient will elicit Katiruja, Kandu, Daha, and Shob. And in next stage, Vyakti, that is stage of manifestation. So here the Bhagendra is going to manifest initially with the Bhagendra Pedika. So this Bhagendra Pedika may be in the three stages. That is Amavastha, Pachimanavastha, and Pakvastha. I hope all of you knowing regarding the Amavastha, Pachimanavastha, and Pakvastha. Then later on it is going to convert into Nadi Varna. Okay, and later on it is going to convert. Next stage will be Bhagendra. The next Bhedavastha. So that is, we can call it as a stage of complication. So here communication of this Bhagendra is going to take place to the different adjacent organs, which we are discussing in the second slide, different organs. That is Basti, it may be Basti, and other organs. And there will be multiple tracks are going to be seen. And there will be continuous discharge of flatus, feces, urine, and semen. Okay. So now coming to the classification of Bhagendra in our Ayurvedic classes. So totally we can come across 8 types of Bhagendra. So those are Shataponaka, Ushtragriva, Parisravi Bhagendra, Shambhukavarta Bhagendra, Unmari Bhagendra, Parikshepi Bhagendra, Riju Bhagendra, and lastly Arsho Bhagendra. But Susruta has only explained or only detailed explanation in Susruta we are going to get regarding first 5 Bhagendra, that is Shataponaka, Ushtragriva, Parisravi, Shambhukavarta, and Unmarvi Bhagendra. And the other 3, that is Parikshepi, Riju, Arsho, so those are explained by Ashtang Sangra, Ashtang Rudhaya, Charanga Samhita. But those like Shusru Samhita, Madhav Nidhan, Bhav Prakash, and they are going to explain the 5 types only. Okay, so this is regarding the classification of Bhagendra. So now we are going to discuss one by one the different types of Bhagendra. So here is the first, that is Shataponaka Bhagendra. So word itself indicates that Shataponaka, Shat means multiple openings which is having. So you can appreciate here in the picture, there are multiple openings here. Okay. So Shataponaka, it does not means only 100. There should be 100. That is, it means multiple openings. So this is external opening in the perineal skin. We can make out. So these are internal openings. Internal opening also may be single or it may be multiple. So this Shataponaka we can compare with the Chalni because it is having multiple openings. Also we can compare this with the watering cans. This is also having multiple openings. So whether the slides are visible once I'm, yes, okay. So this is the actual picture. Yes, so this is the actual picture of Shataponaka Begandara, which we have seen in our hospital, which we have managed in our hospital. So we can appreciate here the multiple openings here. So there is one opening, there is one more opening, here is one more opening, here is also one more opening. So there are multiple openings. That's why it is called as a Shataponaka. So this is a picture of Shataponaka Bhagendara. Then Ustragriva Bhagendara. Ustragriva means just like a neck of camel. So we can appreciate this in this picture. So this is a external opening in the perineal skin. This is an internal opening in the rectum, and this is one more opening which is going upward. So just like a neck of camel. So it is called as a Ustragriva Bhagendara. Then coming to the Parisravi Bhagendara. So Parisravi means what? So which is continuously draining. So for continuous draining, there should be something collection in the surrounding the rectum. So we can appreciate in this picture there is a abscess cavity here. So there will be continuous discharge from this perineal external opening. So that's why we are going to call it as a Parisravi Bhagendara, right? Yes. Then coming to the Shambhukavarta Bhagendara. The Shambhukavarta Bhagendara word itself says that the shape of this Bhagendara will be like Shambhuk, that is Shankar. So we can here also appreciate the Shambhukavarta. So this is the external opening in the perineal skin. It is going to traverse to the external sphincter, into the intersphincter. It is going to come in from the rectum, and then again it is coming from the other part of the rectum, and again in reverse it is going in the rectum. Okay, so this is just like a Shambhuka, that is Shank. That's why it is called as a Shambhukavarta Bhagendara. Yes, then come to the Unmargi Bhagendara. What is this Unmargi Bhagendara? Unmargi Bhagendara is Bhagendara which is created due to the Agantuja karmas. Okay, so here usually in earlier types of Bhagendara we have seen that the pathology is inside, and then the dosha or the track is going to cover. Initially the internal opening is going to develop, and then later on the external opening is going to develop. But in this Unmargi Bhagendara, what is going to happen? As it is due to the Agantuja karma, initially the external opening will be there initially. So we can make out here, and then it is going to spread in the rectum. That's why it is called as a Unmargi Bhagendara, that is in the opposite direction. Yes. Then coming to the Parikshipi Bhagendara. What is this Parikshipi Bhagendara? Parikshipi Bhagendara is nothing but which is surrounding all over the anal canal. So we can make it in this picture also. It is surrounded all over the anal canal. So we can compare this Parikshipi Bhagendara to the horseshoe Bhagendara, right? So this is a Parikshipi Bhagendara. Then Riju Bhagendara. What the word Riju means? Riju means which is straight. So we can make out here in this picture, that is the Bhagendara, that fistula is running straight. Okay, it may be a lower angle, it may be a higher angle. Okay, so that is Riju Bhagendara. Then Arsho Bhagendara. So what is Arsho Bhagendara? Arsho Bhagendara means the Bhagendara which is associated with Arshas. So there will be coincidence of both Bhagendara as well as Arshas. So we can make out here in this picture. So these are the internal pies. This is 11 o'clock, this is 3 o'clock, and this is a 7 o'clock position. So these are the archas. And again this is a picture of, or this is the opening, external opening of this fistula. So the fistula has been inserted and it is taken out from the internal part. So there is an internal opening here. So as it is having both arshas as well as Bhagendara, it is called as a Arsho Bhagendara, right? Yes. Then coming to the management of Bhagendara, which has been explained in our Ayurvedic literature. So this management of this Bhagendara, we can deal under the two headings, that is preventive aspect and curative aspect. In preventive aspect, we have to go with Nidan Parivarjana, we have to avoid suppuration of Pidika, right? And in curative aspect, we are going to smoke. So this preventive, curative, everything we are going to deal elaborately in our next slides. Okay. So in curative, we can deal under three headings, that is medical line of treatment, surgical line of treatment, and parasurgical line of treatment. So in medical line of treatment, we can manage with local treatment or local therapy and systemic therapy. And in surgical line of treatment, we are going to deal under the three headings, that is Purva Karma, Pradhan Karma, Pachat Karma. Again, we are going to deal it in elaborately in the next slide. In parasurgical procedure, we can go with Raktamokshana, Agni Karma, Shar Karma, Shar Sutra, which is the best treatment which is explained in our classic, that is Shar Sutra. Elaborately, we are going to discuss regarding the Shar Sutra also. And lastly, Vati. So these are the parasurgical methods which we are going to adapt for the management of Bhagendra. Yes. Then coming to the first part, that is preventive measures. What we are going to do in the preventive measures? First of all, we have to go with the Nidan Parivarjans, which we have explained in the earlier slides. That is, which are the Nidanas that we have to avoid. The next, we have to prevent the suppuration of Pidika. So Pidika, which is going to develop, that is Bhagendra Pidika, we have to prevent that Pidika to convert into Pakvavastha, that is suppuration. So what we are going to do for the prevention? We are giving the general treatment like Apatarpana, Abhanga, Svedana, Pachana, Vistravana, Snehana, and Shodhana. And local treatment, we can go with Alepa, Parisheka, Vimlapana, and Upna. Yes, then come to the curative measures. Curative measures, as I have earlier told, we are going to deal it under the heading of first medical line of treatment. So what is the indication to deal with Bhagendra in medical line of treatment? So when the Pidika stage is there, when there is a Pidika stage is there, we can try with the medical line of treatment. And already if you have excised the fistula tract, in that case also we can go with this medical line of treatment. So what we are going to do in the medical line of treatment, first we'll discuss regarding the local treatment. So in local treatment, we have to go with Varna Shodhana, Varna Ropana drugs. We can go with Usna Anutela Vasti, Usna Augha Sveda. Okay, so these are the local treatment we can adopt, local therapy. Then come to systemic therapy. So in systemic therapy, we have to go with Deepana Pachan drugs. As all of you are knowing, all the anorectal diseases are due to the Mandagini. So our initial treatment should be to treat this Mandagini. So treating the Mandagini, we can go with this Deepana Pachana drugs. And also along with this, we can go with Mrudu Virechana drugs, Krimigna and Shotahara drugs. Yes. Then come to the surgical line of management. So what are the indications for the surgical line of management? So if there is a failure of medical line of treatment, which we discussed earlier, and also if there is a complicated and agandus type of Bhagendra, then we can go with the surgical line of treatment. So how surgical line of treatment we are going to manage? So as you are knowing, the surgical line of treatment we can deal under the three headings, that is Purva Karma, Pradhan Karma, and Pachat Karma. So what we are going to do in the Purva Karmas? In Purva Karmas, we can go with the Snehana, Svedana, Langana, and Virechana. So we have to go with the lithotomy. We have to view initially the patient before treatment. At the time of treatment, we have to view the patient lithotomy position. All of you are knowing what is lithotomy position. So which are the instruments we are going to use? So Bhagendra Yantra, Yasni Yantra, that is fistula probe. So etc. Instruments we have to gather once early in the Purva Karmas. Then in Pradhan Karma. So Pradhan Karma will be depending upon the condition of the Bhagendra, whether it is a Parachina Bhagendra or whether it is a Arvachina Bhagendra. Parachina Bhagendra, which is Bahirmukhi, which is having external opening, and Arvachina, which means Antarmukhi, that is internal opening. So whether the Bhagendra initially, whether it is having external opening or initially it is having internal opening, depending upon that, we are going to plan the Pradhana Karma. So what we are going to do in the Parachina, when there is external opening, initially we are going to introduce Esni Yantra, that is fistula prep from the external opening. And the whole track we are going to excise surrounding the Esni from the root, right? So this is the method which we are going to adopt in the Parachina Bhagendra. Then in Arvachina. So in Arvachina Bhagendra, that is when there is internal opening, we are going to introduce the Bhagendra Yantra from the anal canal. Then next we have to introduce the Esni from the internal opening. And then we are going to exercise whole track. Just like in the Parachina method, we are going to exercise the whole track along with the surrounding tissues. Okay, and followed by we have to go with Agni Karma and Shar. So obviously after the extension of track, we are going to see the bleeding, oozing will be there. So to tackle that oozing, bleeding, we have to follow the Agni Karma and Shar Karma, right? Yes. Then Shruta has explained different methods of surgery for the Shatapunaka Bhagendra. So we are going to deal in short what exactly the Shruta has told regarding the management of Shatapunaka Bhagendra that we are going to deal. So here one track is excised at once. Even though there are Shatapunaka, multiple tracks are there, we have to initially start with one track. And after healing of that initial track, then we have to manage the other tracks. Okay. So Shruta has explained different types of incision for the management of Shatapunaka. Which are those incisions? So these are Langalaka, it is, we can call it as a T-shaped incision. Ardha Langalaka, we can call it as a L-shaped incision. Sarvatobhadraka, that we can call it as a circular incision. Gotirtaka, we can call it as a semicircular incision. Okay, so this is the management which Sushruta has explained for the management of Shatapurnaka Bhagendra. Yes. Then coming to Ustragriva Bhagendra. So in Ustragriva Bhagendra, Sushruta has explained that we have to go with the total excision of the fistulous tract followed by Kshara Karma. Okay, total excision of the tract we have to do followed by Kshara Karma. Again, to tackle the bleeding, oozing which is there, for that we have to apply the Pratisarniya Sha. But here Agni Karma is contraindicated for this Ustragriva Bhagendra, as it is a Pitta prominent. We are not going with the Agni Karma here. Yes. Then coming to the Parisravi Bhagendra. So in Parisravi Bhagendra, which is continuously discharging, Shrita has explained regarding the excision of the tract, total excision of the tract, followed by Kshara and Agni Karma. And also we can go with the Anutela Vasti. So just like earlier Bhagendra, so Shrita has explained the different types of incision for the management of this Parisravi Bhagendra also. So which are those? Kharjura Patraka, that is branch type of incision. Chandra Ardha, that is semilunar incision. Chandra Chakra, that is circular incision. Suchi Mukha, that is pinpointed, which is the inverted cone incision. And Avang Mukha, that is the previous incision which you have taken in the opposite direction of the previous incision, we have to go with it. Okay, so these are different types of incision which has explained by the Shushruta for the management of Parisravi Bhagendra. The next Shambhuka Varta Bhagendra. So as this Shambhuka Varta is Bhagendra is asadhya, as told in our Samhitas. But here we can go with some of the conservative treatment. Yes, the next Unmarvi Bhagendra. Unmarvi Bhagendra is also told as asadhya because it is created by the Agantuja Karna. So here in Agantuja Karna or in Unmarvi Bhagendra, we have to go with the action of the tract and we have to remove the foreign body which has become the cause for this Bhagendra. And followed by we have to go with the Agni Karma. Here next we have to go with the Krimi Hara drugs. So in this Agantuja Bhagendra, there are chances of infection further on. So to tackle that, we have to go with the Krimi Hara drugs. Yes, then Parikshepi Bhagendra. So we can manage this Parikshepi Bhagendra as explained by Shushruta, just like Nadi Varna management with Kshara Sutra. So basically, or mainly, we are going to deal with the Kshara Sutra here. Yes, then Riju Bhagendra. So here in Riju Bhagendra, we are going for the excision of the tract, followed by Kshara and Agni Karma. Right? In Arsha Bhagendra, we have to first treat the Arsha. Before dealing with the Bhagendra, we have to treat Arsha, then we have to manage the Bhagendra. Okay, so these are the Pradhan Karmas which are explained by the Shushruta for the different types of Bhagendras. Then come to the Paschata Karma. Post operative, what we are going to do? So here we have to go with the Purnashodhana and Gunaropana drugs. We can go with the local Svedana, that is local fermentation with Stadi Sveda, Nadi Sveda, Dodinavava Sveda, Upana Sveda. Here also we can go with Anutela Basti as a Pachata Karma in this management. Yes. Then come to the parasurgical measures. Which are the parasurgical measures which are explained by our class in our classics? Those are Rakta Mokshana. So in Rakta Mokshana, here we are using the Jaloka Ucharana for the Bhagendra Pidika. When the Bhagendra is in the Pidika stage, that time we are going to deal it with the Jaloka Ucharana. Then Agni Karma, we can also deal it with the Agni Karma. Pratisarniya type of Agni Karma we can do here to cauterize the fistulous tract and control the bleeding. Here, control the hemorrhage after the surgery. Then Kshara Karma. So this Kshara Karma, we can apply here Pratisarniya Tikshna Kshara for the fistulous tract. Thus, we can manage with the Kshara Karma. And most important next is Kshara Sutra, which is a gold standard which is explained by our Shushruta in our Samhitas for the management of this Bhagendra. So this Kshara Sutra we are going to deal elaborately in our next slide. So this is safe and effective and very ambulatory management method. So what it is doing, it is cutting to the tissue and laying the tract open, right? Next, after Kshara Sutra, we can deal it with the Varti, that is Aragvadadi Varti. So what Aragvadadi Varti is going to do? It is going to clean the cleansing action and it is going to heal the fistulous tract. Yes. So we are going to deal in short regarding the Patya Apatya, which is explained in our classics. So patya, there are certain cereals like shali rice, pulses like mudga, vegetables like patol, chigru, balamuli, etc. Oil, there's a tila tel, sarsap tel, dhutta. Food preparations like vilepi can be a patya, meat like jangal mouse, and others we can consider as honey. So these are some of the patyas which are explained in our classics for the diseases of Bhagendra. Coming to apatya, so in apatya, vyayam is contraindicated, vyavai, cope, ashuprishtayana, that is riding on the horse, guru ahara, madhya sevana, veghavrodo, these are also apatyas. We can avoid ajirna ahara, asapnya ahara, and sahasa karma. We have to avoid the sahasa karmas. Okay, then coming to the Shara Sutra. Yes, we are going to delete elaborately regarding the Shara Sutra. So what Shara Sutra is exactly? So Shara Sutra is nothing but a medicated thread which is prepared from the Snuhi Kshira, Aparmagakshara, and Haridra. So this Shara Sutra which is prepared with the 21 layers of the above drugs, the drugs which are explained Snuhi Kshira, Apamakshara, and Haridra. The 21 layers of these drugs we are using for the preparation of this thread. Thus, the loop of this thread, the braid which was prepared with the, which we have prepared with the 21 layers, the loop of this thread we are tying along the Bhagandara, and then we are changing this Shara Sutra every week. Okay, every week. So exactly what this Shara Sutra is going to do here? So it is going to cut the fistula tract with preservation of the sphincter mechanism. So that's important. It is going to preserve the sphincter mechanism. So directly we can go with the excision of the tract, but if the sphincters are involved in the Bhagendara, we are not going to go for the total excision. What is going to happen if you are going for total excision? It is going to damage the sphincters. To avoid the damage of sphincter, we are going to use this Shara Sutra, because what it is doing, it is cutting the Bhagendara, along with simultaneous healing is going to take place. So we are not going to damage the sphincters at a time, right? So this is the gold standard method or gold standard therapy which has been explained by our Shuddha, that is Shara Sutra, right? Yes. Then we are going to deal now some of the allopathic counterpart of the Bhagendra, that is fistula in ano. So what is fistula in ano? First we'll see what is fistula. Fistula is an abnormal communication between any two epithelial lined organs. And if such type of abnormal communication is going to take place at the anorectal region, we are going to call it as a fistula in ano. So it may be, or it is a result from the anorectal abscess. The fistula ano is going to result from the anorectal abscess. When the anorectal abscess has developed to the patient, and if it is not tackled properly, if it is neglected, then it is going to convert into fistula in ano. So this fistula ano is also difficult and recurrent surgical disease, right? Yes. Then we will see the etiology for the fistula in ano. So the etiology or the causes for the fistula in ano, we can deal under the two headings, that is non-specific and specific. So in non-specific, we are going to see that there will be cryptoglandular infections. So as all of you know, there are multiple anal glands at the pectinate line. Okay, so this pectinate line anal glands, they are going to infect, and they are going to become the cause for the fistula in ano. So this again sequel of anorectal abscess. Fistula in ano is also a sequel of anorectal abscess. As earlier I have told, if the anorectal abscess is not tackled properly, if it has been neglected, then it is going to convert into fistula. And also the previous pyogenic abscesses. So as abscesses are there, two types of abscesses, pyemic and pyogenic abscesses. If there is patient is suffering from any previous pyogenic abscess, then it may lead to the fistula formation. Okay, so these are the non-specific etiological factors for the fistula in ano. Now, specific factors or specific causes such as secondary to tuberculosis, secondary to anal fissure, secondary to ulcerative colitis, Crohn's disease, colitic carcinoma, secondary to foreign body intrusion, secondary to pelvic inflammation, and trauma. Okay, so these are specific causes for the development of fistula in ano. Yes, then we are going to discuss regarding the symptomatology, symptoms. So in symptomatology, there will be continuous seropurulent discharge from the fistulous tract from the external opening, as well as it may be from the internal opening. There will be continuous purulent discharge. And if the external opening is occluded, that is closed, if the external opening is occluded, what is going to happen? The patient will develop pain and swelling. Patient will be going to develop pain and swelling. But when the external opening has been occluded, yes, again, the patient will be having pruritus ani. Pruritus ani means there will be itching surrounding the anus in the perianal skin. Okay, these are the symptoms which patient will be having in the case of fistula ani. Then coming to examination part. So on examination, we can see single or multiple external openings. Okay, there will be local inflammation. There will be induration. Induration means there will be hardness at the palpation part. Okay, there will be local inflammation on inspection. Also, there will be fistulous tract can be felt in between the index finger and rectum, in the rectum and thumb outside. So we are doing a digital examination. Okay, in per rectal examination, at the time of digital examination, we may feel the fistulous tract in between the index finger inside in the rectum and thumb outside on the perianal skin. So we can feel a cord-like structure, that is fistulous tract. Again, occasionally we can feel internal opening just like a nodule on an anorectal wall. So in digital examination, occasionally we can feel the internal opening of the fistulous tract just like a nodule on the anorectal wall. Yes. Then classification. Classification of fistula and ano. So classification of this fistula as ano is explained in two parts, or two types of classification is explained. That is past classification, which we are using routinely. Again, it is told as a Morgan's classification also. So initially we will see regarding the past classification. So past classification is nothing but past classification is told in the four types. That is intersphincteric fistula, which is seen in the 45% cases. What is this intersphincteric fistula? So intersphincteric fistula is nothing but the fistula which is confined to the intersphincteric plane. So that is the fistula is present in between the external sphincter and internal sphincter. Okay, so that is called as intersphincteric fistula. That is seen in 45 cases. The next, what is transsphincteric fistula? Transsphincteric fistula is nothing but which is going to traverse the external sphincter. It is going to communicate with the ichiorectal fossa. Okay, that is going to communicate with the ichiorectal fossa. Then suprasphincteric fistula. What is this suprasphincteric fistula? Suprasphincteric fistula, which is going to extend in the upper part, that is the cephalic direction, or the extrasphincteric fistula, external sphincter, or the external sphincter. As I have told, there are two sphincters, external sphincter and internal sphincter. So the suprasphincteric fistula is going to extend in the upper side in the cephalic direction over the external sphincter, and it is going to perforate the levator ani muscle. Okay, we are going to see the pictures of these types of this classification. Okay, and then next, extrasphincteric fistula. What is extrasphincteric fistula? This extrasphincteric fistula is going to extend from the rectum to the perianal skin, external to the sphincter apparatus. It is going to extend from the rectum to the perianal skin, which is external to the sphincter apparatus. It is nothing to do with the sphincter apparatus. Okay, so this is one classification, that is past classification. One more classification, it is explained, that is Morgan's classification. What is this Morgan's classification? Morgan classification is based on the level of internal opening in relation with the anorectal ring. So this classification is depending upon the level of internal opening, where exactly the internal opening has opened in relation with the anorectal ring, whether it is upper to the anorectal ring or whether it is lower to the anorectal ring. Depending upon that, this Morgan's classification has been told. So it is classified as low level fistula and high level fistula. So what is low level fistula? Low level fistula means open, which is going to open in the anal canal below the anorectal ring. So it is going to open below the anorectal ring. That is low level fistula. High level fistula, which is going to open in the anal canal just above the anorectal ring. Then, so one by one, we are going to deal in short regarding the different types of sphincters. That is intersphincteric fistula. We can see here the fistula is running in between the two sphincters, that is external sphincter and internal sphincter, right? Yes. The next, transsphincteric fistula. So transsphincteric fistula, which is going to traverse both the sphincters, external sphincter as well as internal sphincter. So here it is the external opening and here it is the internal opening. So that sphincter which is going to traverse both these sphincters is called as a transsphincteric fistula. Yes. Then suprasphincteric fistula. What is this suprasphincteric fistula? The suprasphincter which is going to extend in the upper part. You can see here it is going to extend. This is external opening, it is going to extend upward side, it is going to above the external sphincter, and it is going to pierce this levator ani muscle. Yeah, it is going to pierce the levator ani muscle, and it is going to spread here. Again, it may open into the anal canal or rectum. That is suprasphincteric fistula. Then Good-Salz rule. What is this Good-Salz rule? So you might be knowing what is Good-Salz rule. So this Good-Salz rule relates the location of the internal opening depending upon the external opening. So we can make out where exactly or where maybe the internal opening just looking to the external opening. So it will be very useful at the time of management where the internal opening has done. So here what we have to do here, we have to draw imaginary line across the midpoint of the anus. So you can see here, we have to draw the imaginary line across the midpoint of the anus. And if the external opening is anterior, so you can see here, if the external opening is anterior to this midline, then what is going to happen? The fistula is going to run straight directly into anal canal. You can appreciate here in the picture. So as the opening is in the anterior part, it is going to open straight in the straight manner in the anal canal. And suppose if the external opening is behind or posterior to this line, then what is going to happen? The fistula is going to be curved fashion and the internal opening will be in the midline posteriorly at the 6 o'clock position. So that is the rule. When it is anterior, it is going to open in straight manner. And if it is in the posterior part, it is going to open in the curved manner. Okay. But there is exemption for this rule. What is that exemption? If the external opening is anterior, even though it is anterior, but it is situated beyond the 1.5 inch, that is 3.75 centimeter. Beyond this circle, if it is away from anal verge, that is 1.5 inch, then what is going to happen? The fistula takes curved fashion. Sorry. The fistula is going to open in the curved manner. And again, it is going to open in the posterior midpoint. So you can make it here, even though it is anterior to the mid transverse line, but if it is beyond the 1.1 inch from the anal verge, so again, the fistula's internal opening will be in the posterior midline. So that is the Good-Salz rule with exemption to the rule. Yes. So now management principles of management. In the allopathic part, we can go with the non-surgical procedure, surgical procedure, and parasurgical procedure. In non-surgical procedure, we can have the drugs like 4% silver nitrate, bismuth sulfate, quinine, urethane. We are going to deal elaborately next slides. Next, surgical management, we can go with the fistulotomy. Just we have to open the fistula. Next, fistulectomy and fistulotomy in surgical management. And next, in parasurgical management, we can see the Seton divisions. What is the Seton division? Seton division is nothing but the allopathic counterpart of the Shara Sutra. We are going to deal it elaborately in next slides. Yes. Then come to non-surgical management. So non-surgical management is unpopular. What we are going to do here, we are injecting the medicaments into the fistula tract. So we are using here 4% silver nitrate, bismuth paste, quinine, and urethane. But there are some disadvantages of this treatment. So which are those? There will be recurrence, there will be inflammation and necrosis of the surrounding healthy tissue. Then surgical line of treatment. In surgical line of treatment, we can go with the fistulotomy. So what we are doing here, we are just incising the fistula tract and laying open. We are taking the incision here and just we have to keep the fistula open, lay open, and followed by we are doing the curettage of the underlying unhealthy tissue. The unhealthy tissue which is present in the inside of the fistula, that we are going to do the curettage of that. Okay, after the incision. But there are also chances of recurrence in this fistulotomy. Then fistulectomy. So what we are doing in fistulectomy, we are excising, total excision of the fistula tract with surrounded unhealthy tissue. We are excising the fistula tract, but along with the fistula tract, the surrounding unhealthy tissue, we are also going to excise. Okay. So what problems we are going to face in the fistulectomy? There will be wide open wound. Also, there are chances of separation of the end of the sphincter. There are chances of damage of the sphincters. Also, it will take longer time for the healing. So there may be chances of fecal incontinence and there will be chance of recurrence, right? So what are the post-operative complications in the above surgical methods? The patient may have urinary retention, patient may develop hemorrhage, patient may have incontinence, patient may develop acute external thrombosis due to the earlier procedures, patient may develop cellulitis around the surrounding skin of the anus, patient may also develop fecal infection, there will be recurrent fistula formation, rectovaginal fistula will develop, that is the connection between the vagina and vaginal wall and rectum, and there will be persistent sinus. And lastly, patient may also develop the stricture of the anal canal. Yes. So what's the line? Yes. Post-operative complications are on the next. Next slide. Just a minute. Just a minute. Whether the slides are visible here?
Yes, sir.
Yes. Now we are
Yes,
going to
sir.
going to discuss the parasurgical method. Parasurgical method, which is explained by the Hippocrates. Parasurgical method is nothing but we are using here Seton division. So this Seton division is nothing but a allopathic counterpart of Shara Sutra, which we have explained here. So this is explained by the Hippocrates in 5th BC. Okay, 5th BC, this Seton division is explained. And this Shara Sutra is explained earlier by our Shishruta long back before this 5th BC. So what are the indication for using this Seton? So here the indication for Seton division is high level fistula, suprasphincteric fistula, extrasphincteric fistula. Okay. So which are the Seton materials we are going to use here? We are going to use like silk, nylon, silver wire, and proline as a Seton material. So what we are going to do here, we are tightening the Seton, that is silver, it may be silver wire, nylon, silk, in the interval of 2 to 3 weeks, and it is going to divide the sphincter gradually. So you can make out that the Seton is going to divide the sphincter gradually. It is not going to cut the sphincter at a time. If it is going to cut the sphincter at a time, there will be chances of incontinence. But what this Seton division doing? It is cutting the sphincter. Even though it is a sphincter, it is cutting, but it is gradual cutting. Simultaneously, there will be healing and cutting. Okay, that's why there will not be an incontinence. So what it is going to do? It prevents the accumulation of pus in the tract. The Seton is going to prevent the accumulation of pus in the tract, and it allows for the drainage of the pus. Okay, drainage properly. Then it also avoids the fecal incontinence because it is going to preserve the pivorectalis muscle. So as the pivorectalis muscle has been not damaged due to the Seton, we are going to avoid the fecal incontinence, right? Then what exactly is the Seton division? So it is a tight loop of wire along the fistula tract, which is gradually tightened over a period of weeks. So it is just like a Shara Sutra. We are going to tie the loop of wire along the fistula tract, and which is going to, we are going to gradually tighten it over a period of weeks. So in Shara Sutra, what we are doing, we are changing the Shara Sutra every week, but here we are just tightening the knot of that Seton every week. So this is again, it is explained by the Hippocrates in the 5th BC, but the Shara Sutra I have told earlier is explained by the Shishruta long back before the Hippocrates. Okay, again the Seton material is silk, nylons, rubber, proline, and we can tighten this Seton at the interval of 2 to 3 weeks. So you can see the picture here of Seton division. So the loop has been, the Seton has been passed from the external opening, it has taken out from the internal opening from the anal canal, and it has been tied. And this is not we are going to tie, and this knot we are going to tighten every week or in between the interval of 2 to 3 weeks. Okay, there is Seton division. So what exactly mechanism is going to take place in this Seton division? Yes, it is going to cut the fistula. It's going to cut through the fistula with preservation of sphincter mechanism. That's important. Even though it is cutting the fistula, it is going to preserve the sphincter mechanism of the anal canal because it is not going to damage the sphincters, right? So we can have some example, that is principle of what exactly that Seton is doing. So we can take an example. Use of Seton as a therapeutic tool is analogous. What is How it is analogous? It is analogous to that of wire cutting to the block of ice. What we are doing, we are taking a block, ice block, we are tying a string here and we are tightening it. So when we are tightening the string, it is going to cut the ice block. Even though the ice block is cutting, the upper part is going to adhere once again due to extreme cold of that part, of that ice cube. There will be extreme cold. Even though we are cutting the cube, there will be again adherence of the upper part of the ice cube. The same mechanism here we are going to follow in this set-on division. The ice is still adherent after the division by the wire. Can you make it? So ice we are going to cut, but it is still adherent after dividing of the wire, because we are not cutting the ice cube suddenly. We are cutting the ice cube gradually. So that's why it is going to heal from the upper side. The same mechanism or same principle is we can see in the Shah Sutra as well as set-on division. So what is the excellence of Shah Sutra over the set-on division? Now we are going to discuss, or we are going to see what is the excellence of Shah Sutra, which is explained by our Sushruta long back. So what is the excellence? First excellence, it is having minimal trauma. There will not be a tissue loss, no bleeding in Shah Sutra application, and anesthesia is seldomly required. For the management of Bhagendra, as fistula tract with Shah Sutra, anesthesia is seldomly required. Patient is fully ambulatory. Patient can be easily movable, okay, after surgery. Then also there will be minimal hospital stay if you have managed with the Shah Sutra. There is no chance of incontinence. Therapy is costing very less, and there will be very narrow and fine scar we can see post-operative. There is no anal stricture. There is no anal stricture. Recurrence rate is practically nil. So here recurrence rate is practically nil in Shah Sutra application. Yes. So now we'll see Shah Sutra versus set-on division. What is exact differentiation we can make out from the Shah Sutra and set-on division? So the first column is of Shah Sutra, second column is of set-on division. So here in Shah Sutra we are using the medicated thread, but here we are not using the medicated thread in Shah Sutra. In medicated thread in Shah Sutra, what we are using, as I have told earlier, we are using the Apamaraga, which does the Lekan Karma. We are using Snuvik Shira, which does a proteolytic action. Haridra, which will do a Vradana Shodhana, Ropana, and Karmigna. So we can say that this is a medicated thread, but the set-on is not a medicated thread. So draining and cutting is done by both Shah Sutra as well as set-on division. Debridement is going to take place in Shah Sutra because we are using here Shah. So the such type of debridement we are not going to see in the set-on division. There will be faster healing as we are using here Haridra. Faster healing will be there in the Shah Sutra, and there will be delayed healing in set-on division. We are going to change the Shah Sutra weekly. We are going to change it, but in set-on division, just we are going to tighten the knot every week. And regarding the unit cutting time, so specifically the unit cutting time has been mentioned in the use of Shah Sutra. That is, in 7 days we are going to cut the track for 1 centimeter. But this unit cutting time is not specifically mentioned in set-on division. Right? In next slide, in Shah Sutra there is no incontinence, but we may see there is chance of some flattest incontinence in set-on division. Cure rate is more in Shah Sutra. The cure rate is least with respect to the cure rate. Okay, there is no chance of infection in Shah Sutra. The infection rate is more in set-on division. There is less recurrence of the Shah Sutra, and there is more recurrence in set-on division. So these are the differential features we can compare easily with them. Okay, then coming to our last slide, conclusion. So in conclusion, we can say management of fistula and ano needs a complete knowledge of anatomy. Management of fistula and ano needs complete knowledge of anatomy of the anal canal as well as the pathophysiology. Almost all surgeons, starting from the Sushruta to Hippocrates and modern surgeons, realize different course of diseases. So almost all surgeons, starting from Sushruta, Hippocrates, and modern surgeons, have realized the difficult course of disease. How difficult is the fistula to treat? And it is mentioned different types of surgical, parasurgical, and medical line of management. Still, it remains a challenge even for a skillful surgeon. Still, the management of fistula, it remains a challenge for a skillful surgeon. Shah Sutra therapy is still gold standard technique, which is explained by our acharyas. Shastra therapy is still a gold standard technique. Yes. So, lastly, so it's not an exaggeration to say that many modern modalities are developed either on the basis or with the clue from the Ayurvedic science. Right? So I have one example we have seen here, Shah Sutra and Saturn region. This Shah Sutra has been explained long back by our acharyas. The Saturn region is explained in the 5th BC by Hippocrates. So we can say that it is not an exaggeration to say that many modern modalities are developed either on the basis or with the clue from the Ayurvedic science. Right? Yes. So what we to do, we people need to do, just we people need to compare and contrast our surgical skills in the light of modern techniques. Okay, just we people have to compare our skills, contrast our skills in the light of modern techniques. There are some modern advanced techniques which are having that we have to compare, that we have to use, we have to utilize to pull ourselves into the mainstream of modern era. So along with this help of this modern technique, we have to pull ourselves in the mainstream of modern era. So what we have to do, we need to go hand in hand. We need to help our colleagues. We need to support our colleagues. We should not drag those, and we need people to go hand in hand. Okay. Also, we can take help from the modern peoples, and we have to reach to our goal. Okay, that's all. So now let us go to the lethal word of this golden leaf. Thank you, everyone. Yeah, over to Dr. Amit. Over to you, please.
Thank you, Dr. Shekhar Patil, sir, for sharing with us such a valuable knowledge regarding Baghandar's clinical aspect. Now, I request Dr. Asavari Golab for a vote of thanks. Towards you, Dr. Golab.
Madam, unmute yourself.
Hello. Thank you, Dr. Snehali. Thank you, Dr. Snehali.
State Department of SHALYA has arranged a national webinar on clinical aspects of colorectal diseases. On the behalf of SHALYA Department, L.R.P. AMC Islampur, myself, Dr. Asavari Golab, Assistant Professor SHALYA Department at L.R.P. AMC Islampur. Giving my vote of thanks to eminent speaker, Dr. Lakshmikant sir, Professor PhD Guide at Department of SHALYA, Shri BMK Ayurved Mahavidyalaya, Shahpur, Belgavi. For giving a wonderful lecture over the clinical aspect of rectal carcinoma. I am also very much thankful to Dr. Shekhar Patil sir, Assistant Professor at Department of SHALYA Department at Vasantdada Ayurvedic Medical College, Sangli, for his delightful lecture over the clinical aspect of Baghandara. I would also like to thankful Honorable Sri Nishikant Bhosle Patil Dada, founder Prakash Shikshan Mandal Islampur, for his valuable guidance and support. I am thankful to Chairman Sri Sanjay Yadav sir, Nitin Patil sir, Sandeep Yadav sir for their support. Our department is very much thankful to this respected Dean Virendra Menkere sir for his guidance and cooperation. Our department is thankful to our PG Director Pramod Kanab sir, PhD Director Ajit Patil sir for their valuable support. We are deeply grateful and thankful to all the respectful teaching facilities of our institute and other institutes for their active participation in the webinar. I am thankful to all PG students, UG students, and all the audience for their active participation in the webinar. I am also thankful to our institute ICTC department, Mr. Shailesh Katkar sir and their team for their support and valuable time. Thank you very much, sir. Once again, I am thanking one and all. And at the end, I am requesting to all to fill up the feedback form in the given link to get the e-certificates. Thank you. Thank you all.
Thank you, everyone. With this, we are to the end of this webinar. Thank you once again for all your valuable time.